So I've got 4 uro-oncologists, 2 radiation oncologists, and 2 medical oncologists. Dr. Nagendra Sharma, Dr. Yashwant Kashyap, Dr. Amit Kumar, Dr. Shashank Saini, Balchandra Kashyapi sir, Anand Raja sir, Pankaj Panwar, Priyamvada Maitre, and Dr. Kaustav Talapatra. What's your name? Amit Kumar. Okay. Yashwant. So 2 medical oncologists. Yeah. Okay. Niche. Fine. We'll start off, and nothing personal, but everything is personal. So I was just telling to Priyamvada that anyway you will come even if it's uninvited, like every radiation oncologist, so you might as well just be there. Okay, so after discussing each of the paper, I would like voting from the audience, that's one, and I would like voting from the panel, and if neither of them match with what I want, then I'm the dictator, so I'll decide whether we take it into account or not. So I want 3 things. One is, yes, we are going to remember this tomorrow and it is going to change our practice. No, it doesn't. It just doesn't add to anything we know. And the middle one is, we are not sure, probably we need a bit more evidence on it. Okay? But as I said, as I am the moderator, I get to vote as the last one. Yeah? So let's look at the investigation part of it. I'll start with Anand Raja, sir. And what I want you to take into account is, we have got the 2 setups, institutional setup like TMH or Basavatarakam, and then the private health setup. Whether we like it or not, both of them exist and both of them tend to thrive. So we got to take both of them into account in answering our question. Let's not say, in TMH, this is what we do. Okay. 65-year-old having, because our investigational pathway is not in a coordinated fashion, has a hematuria, goes to his local radiologist, gets an ultrasound scan, 3 centimeter mark, urine cytology is positive. Anand Raja sir, what would be your next investigation?
CT scan.
Okay, CT scan is done. You won't do an MRI scan?
So
Yes or no?
yes, I do an MRI scan.
Okay. After CT scan?
After CT scan.
Okay, what are you looking for in CT scan to decide when to do MRI scan?
So if there is gross extravesical disease that I have already seen, there is disease, nodal disease is already there, retroperitoneal nodes are already there. If I see that there's already T3 plus disease or T4 or node positive disease, then I don't do an MRI scan. I only do an MRI scan if I see that there is disease which is where I cannot make out muscle invasion. So in those group of patients, we do an MRI scan to check for virads and see whether we can avoid a TURBT. We've done a little bit of work on that.
What would be a step after that? Balchandra Kashyapi sir. So he said he would do a CT scan, and if it is a bit of a query between T1 and T2, he would do an MRI scan. Is he talking because here he is on a Sunday, or do you think that's what he practices on Monday as well?
No, for a larger bladder tumor or 3 centimeter or higher, I would primarily do an MRI and not do a CT to begin with.
Why are you doing a CT? Why can't you just jump to an
No,
MRI?
the MRI, we are doing it as a pilot study to look at virad standardization, so on and so forth. We've done about 40 patients, 20 patients with virads.
Okay.
So
we are talking of clinical practice.
So that we are doing as a pilot study to standardize our virads reporting rate, whether 1, 2, 3, 4 and 5.
In your clinical practice. So you do an MRI scan, you don't do a CT scan. Because I was just thinking, if you are anyway doing an MRI scan, what additional information would you get in a CT? Other than a study wherein you are comparing which one gives me more.
It's difficult to standardize a virad scoring. Different radiologists report it very differently. It's very difficult to standardize. We are going to take decisions based on an MRI. So to standardize all that, we are doing an MRI.
Okay.
But apart from that, I just do a CT scan and take decisions based on that.
Okay. I'll do this way around. Are we still there wherein we are deciding based on an MRI scan? Kashyapi sir.
We are not there yet.
We are not there yet. So you need to work with 1 or 2 radiologists whom you can rely.
Okay.
And you need to give them a feedback after your TURBTs also.
Okay. Pankaj Panwar? Yes.
So
What do you do?
I think I would not be very fond of MRI in the beginning, but CT urogram would be the first investigation.
Okay.
Talking about the bladder part trial.
Why is it for you?
So because as I said, in this case, a 3 centimeter tumor, CT can give us enough information. Unless I have a doubt of muscle invasion, then I will prefer the MRI. But I think T3 versus T2 I can distinguish from CT.
I think we are answering quite a lot because we are here on a Sunday. I don't do an MRI scan. The reason why I don't do an MRI scan is muscle invasion or not is a histopathological diagnosis. Still, 2025, that's where we are.
I agree.
Okay? So this, yeah, upper tract MR urogram will give us the answer. Would CT any better than MR urogram? I don't think there is any evidence of that.
I don't think there's any evidence for
Yeah,
that.
so upper tract assessment is a part of it, but for the bladder one, okay? So this one they said, again, it's a good enough one, but we have to understand what actually they are trying to tell us. Did they stop them from having a TURBT? No, they ended up having TURBT. They are only looking at when was the cystectomy done, yes? So would you say this is of relevance to Indian practice or not? If it is not of Indian relevance, there are loads of thumbs down.
No, I think the main endpoint of the trial was they did this trial to see when it is that they could do the cystectomy.
Yeah.
There's loads of data to suggest, loads and loads of data to suggest that from time of diagnosis to cystectomy, if it's more than 90 days, it leads to inferior survival. And their numbers are far more than 90.
No,
in our
that,
country,
that
it's-
wasn't the question. So adding an MRI in the overall pathway, does that change anything with respect to shortening the pathway?
I don't think that's relevant to our country.
Okay. So I have, as I said, I'm the
Sir.
dictator. I've said yes. The only reason for that is I've taken institutional practice and private practice into my. If a patient comes to me today, I can do a TURBT on him tomorrow in Apollo. In TMH, he might wait longer. Yes? No, I'm just saying institution. So in case if you were triaging, it might help in the triaging. It would not be reducing 45 days, but it will help us to say a patient, because all these patients underwent a flexible cystoscopy. So what they were doing is, all of them had a flexible cystoscopy. Somebody looked at it and said, this looks muscle invasive. That's when they went into the trial. So you have already done this initial assessment. So once you have done it, the triage part is done, but we don't have flexible cystoscopy as a diagnostic investigation tool in India. So if you exclude that, you can use an MRI as a part of the investigational pathway and say, yes, this one looks like a muscle invasion, we need to move on a bit. That's why I said thumbs up, and that was a rationale for it. So I have overrode what you have said by a lot, because that was the only reason. All these patients underwent a flexible cystoscopy. All of them were doubted to have a muscle invasive disease. That's the reason they were randomized. Am I fair in doing that? Yeah, go ahead. Yeah. One
I
comment.
was part of this, my institute was part of this trial in bladder part trial in UK, where I was there 5 years. So, I mean, you are rightly said, the flexible system, these are pathway driven trials, which is what
Yes.
they're trying to cut down the timing for the definitive treatment. I don't think so it's practical in Indian situation at the moment. And also it's a variable because the flexible cystoscopy pictures made the idea whether they are going to go for MRI or not. And they were mostly doing biopsies of these tumors based on the at the flexible cystoscopy timing itself.
Yes.
To prove that there is actually histological evidence of cancer. And also there are a lot of parameters which will miss, including the, of course, proper staging of the tumor, variant histology, which are very relevant in terms of, and also I'm not sure how medical oncologists are comfortable in
No, as
giving
I
a
said,
chemo.
right
Yes,
from
sir.
the beginning, in that currently we are not in a stage of using an MRI for it to tell me whether we are muscle invasive or not muscle invasive. Yes?
And also, sir, NACT can't be given if we don't have a histological muscle.
No,
invasive.
again,
I
I'm
was just
going
thinking.
to the same one. Is that relevant to us? The only relevance for us is in triaging the patient. I'm not saying whether I would do a TRBT. I would do TRBT on 100 of my patients. Just say that we know where we are. Okay? This one I found it very difficult. This is how probably we should not use AI or big data to tell us what to do. The numbers are big, so they found a conclusion and then they're trying to find a reason why the data is showing that. If anybody can make more sense out of this, so the numbers are big. Okay, so I'll just, I'll go to Pankaj Vanumar, I've done. Shashank Saini. Okay, so you do a bladder tumor resection, any bladder tumor resection. If you did 10 bladder tumor resection, when do you do your next check cystoscopy? I'm just saying randomly, when would you do your next check cystoscopy?
Sir, for us it is at 3 months, sir.
Generally, it's around 3 months,
yes,
3 to 4
around that
months.
time,
Okay,
yes, sir.
that's generally is our average. Unless you'd started doing a redo resection or any of them when you're worried, you
That is
might do it a bit earlier. Yeah, generally 3 months is what. I think that's what this has shown. In that cystoscopy within 2 to 4 months is the majority of the patients. 16,000 or 17,000 of the patients underwent. So they said the cystoscopy as a determinant, when you do your next cystoscopy as a determinant of the overall outcome. I've found it very difficult to comprehend the data or come up with anything useful. Yeah, go ahead.
So either way, they have it at between 3 to 4 months, because if
Yes.
you do a TUR, they'll have it at about 3 months. If you do a re-TUR, they'll again have it at about 4 months. So that 3 to 4.5 month window, with or without the induction BCG, is when majority of them would anyway have it.
Okay. So this is what, when you analyze big data without the histology, without any clinical information, this is what it throws out. So there were 2 take-home messages. Generally, we tend to do it around 3 to 4 months, which is what we all agree. Then the second one is, if somebody doesn't have a cystoscopy until 8 months, again their survival seems to be inferior, which is again understandable. They have gone off, they have never come back to you. These were all insurance patients. So they didn't come back to you, so that's the reason they have got. But those were the 2 points that I could make, and I don't want to go any more detail just because it's not relevant to our practice. Thumbs up or thumbs down? Oh, thumbs up there. You understood something that I didn't understand then. What would you say? Thumbs down, okay. So that's what I said. It's not relevant to our day-to-day practice. Okay. So this one, again, quite a relevant one. The variant histology make a difference. Balchandra Kashyapi sir, makes a difference. Priyamba, the next will be to you.
Yes, it does make a difference.
Okay. For you, it makes a difference?
It does make some difference.
Okay. Not as much as it makes a difference to us. Okay, so these were all 40 patients who had variant histology. They were matched to 40 patients who had normal urothelial carcinoma. That was one. And second, all of them had TA-T1. They did not have muscle invasion on the initial assessment. So all of them had either urothelial or variant, and the clinical diagnosis was TA-T1. And I was surprised with the numbers. If you look at it, this is the upstaging that tends to happen. If you see this, squamous cell carcinoma upstaged in 75, 87, 62, 80, 40, sarcomatoid 100. So almost whenever there is a variant pathology, majority of them, there is an upstaging. When I'm saying majority, more than 51%, majority of them are. So these were all TA-T1. Whenever it's a variant pathology, expect that they have more than that. Okay? So that was my one take-home message. Is that a good enough learning point? Yeah? I thought it was a good enough learning point. So whenever it is a TA-T1 variant histopathology, majority, 70-80% of them are upstage to anything more than that. Okay? BCG unresponsive. I think there are 3 papers in this one. And even now radiation people have gone on to this one. Yeah, compared to okay, just a broad statement to somebody. I asked everyone, but I'll ask again. Anand Raja sir, what does intermediate risk NMIBC mean to you?
It's a basket. What is not high risk and what
Okay,
is not low
don't
risk
give
comes
me
in.
don't give me an answer in negation. Give me an answer in positive. What is, in your view, intermediate? Balchandra Kashyapi sir, I'll be asking you the same. What is intermediate risk? It took me some time to work this out. That's the reason I was intermediate risk bladder cancer.
Oh, it is what is not high risk and what is not low risk is
Give
is
me a
something
positive answer on that.
That a multifocal T1 low grade, something like that would be an intermediate risk.
Okay, I'll give you a bit more. There are 2 lesions, less than 2 centimeters. Kashyapi sir, this is high grade TA. Is this intermediate or high risk?
This is a high risk.
I thought so as well, but it isn't. This is intermediate. So high grade TA, single lesion less than 3 centimeters, is high grade, not high risk, it's intermediate
I
risk.
feel it's safer to keep them as low risk and a high risk.
No, I'm not going by what I feel about it. I've just got the EAU guidelines on this. So if you look at it here, G3T1 is high risk. There is no G3TA. Only where it comes G3TA there is if there are more risk factors like patient being less than 70, patient has got multifocal disease which is more than 3, or the lesion being more than 3 centimeters in size. So if there is a 2 centimeter lesion which is categorized as a high grade TA, it is intermediate risk. And only when they had this many patients, I had to say, it's very difficult to find intermediate risk patients. So when you go back and say, how did they find this many? That's what was. So majority of these patients were high grade TA, which we generally tend to categorize as high risk. But if you follow the literature, both AUA as well as EAU categorizes them as intermediate risk bladder cancer. Okay, so G3TA without those risk factors, if it is unifocal, less than 3 centimeters size in a younger patient, it is considered as intermediate risk. That was my learning point from this. I didn't know that. I had to go through each one of them and tick them. That's why I was asking you, in a positive way, how do you identify an intermediate risk? My answer was that same. What doesn't fall into low risk, what doesn't fall into high risk falls into intermediate, and multifocal, recurrent, low grade TA is what my answer was. But following this one, it is high grade TA, single lesion less than 3 centimeters is intermediate risk. So Kaushik Kolunukoduru, he is son of Subramaniam sir in Apollo, Hyderabad. This guy he published 24 papers in last year. He is in Mount Sinai, published 24 papers in a year. Got into Weill Cornell training for urology, but published 24 papers in 12 months. So this one, that's the reason I said pre-treatment pathology was high grade TA in 65% of the patient before the treatment. So that's the reason. So these were intermediate risk bladder cancer where the BCG makes any difference compared to gemcitabine and docetaxel. And the answer is no, BCG is better, both with respect to any recurrence, with respect to high grade recurrence. So that was my learning point. That's why I given a thumbs up. All of us agree? So in an intermediate risk, though we tend to think that they are high risk, in intermediate risk, BCG is better. Numbers are small, all those deficiencies are there, but intermediate BCG is superior to gemcitabine docetaxel. Okay? This is again a more difficult one. Long-term outcomes from bladder sparing therapy for BCG unresponsive. That was BCG naive patients, BCG unresponsive. So what are your options, Anand Raja sir? Sorry, I'm still with urologists. I'll come to the medical oncologists in the middle and the later part. Okay.
So once it's BCG unresponsive, I mean the options we have are really very
if
limited
you have
options.
100 patients who are BCG unresponsive, fit enough for cystectomy, how many of them you offer cystectomy, how many of them would you offer something else? You would offer means do.
Depends on the timeline of recurrence. So that's the first thing that will happen.
Recurrence within 6 months.
If it's within 6 months, I think most of them I would offer cystectomy rather than go for.
Kashyapi sir, would you play around with any of the other ones? No. Okay. So early recurrences, if they are late recurrences, say 2 years, are they different?
Then we'd play around with some of these agents. We'd give.
What do you play around with? Reinduction BCG or gemcitabine docetaxel?
If it's more than a year, then it's reinduction BCG. Otherwise, it's gemdosi. We've also given doxorubicin, mitomycin. So we've given all of these.
Do you follow the same, sir, Kashyapi sir?
Yeah. More than, if the recurrence is later, more than 1 year, 2 years,
You might go for.
you could offer a reinduction BCG
Okay.
if it was well tolerated earlier.
Okay, fine. So this is what they have done. BCG unresponsive patients. So quite a lot of 40% of them continue to have the BCG. And this is just looking back at a case series and say what happened to them, rather than saying that this was a randomized trial or anything. And alternative in 36. So majority of the patients either BCG continued or they tried other modality of chemotherapy. Okay? Am I fine in saying? The reason why I'm saying that is They say that there is no cancer-specific survival, but the follow-up was around 3 years. They extrapolated it to almost 10 years. And this is what they say. Treatment of time from BCG failure, if they undergo radical cystectomy compared to bladder sparing, there is a difference. For me, I'm very worried whenever anybody faces a BCG failure or a recurrent disease following BCG, something has to be done. And the primary option that I provide them is cystectomy. Only if they are not fit enough. Priyambada, your time will come.
So I have this thing. See, the most effective therapy for intravesical therapy is some sort of immunotherapy that we give inside the bladder, which is far more effective because they are durable responses, unlike chemotherapy,
Yes.
which is short-term. So if the most effective therapy that you have is not worked, BCG, within 6 months to a year, the possibility that some chemotherapy is going to work is going to be negligible. So that's why, a lot of them will go on to the cystectomy. But if it's worked for a long time, chemotherapy may or may not work.
I'm going to use your answer now for a later part. Patients who haven't responded to BCG, you have done the rigid cystoscopy TURBT, it is still T1. Okay? You say you offer cystectomy. What is the 5-year survival you are quoting for BCG unresponsive T1 at resection after induction BCG?
No. So T1, was it as a lower grade or is it the
High
same?
grade T1.
High grade T1.
You offer cystectomy. What is your 5-year survival?
I haven't looked at my numbers,
No,
but
what do you quote?
it'll be about 80% maybe.
Okay. You agree with that, or you think it's higher for a high grade T1?
80 to 85%.
80 to 85% 5-year cancer-free survival. Okay. We'll use that number later. Okay. So this one, I'm not sure. My view currently is cystectomy is the primary option. Other options are you can offer them only if the patient is not fit enough or would not survive a cystectomy. Okay. So this one, bladder sparing therapies. Yeah, this is, okay, the consensus statement. We have to say, just look at what the consensus statement was. So here, if you see there, for CIS, how often do you see CIS on its own? Pankaj Panwar.
Sir, not much in India setting I have seen.
Okay.
But in
India?
No, not much. But in outside India, it was almost 40-45%.
It was there quite a lot. So here, when you look at it, BCG, urothelium with CIS. Unresponsive just with CIS. I haven't seen just CIS at all. We used to see that in UK, but not in India. Okay? So only this one is relevant to us. So if they are unresponsive, high-grade papillary, give them induction and maintenance doublet with gemcitabine docetaxel. Single agent chemotherapy, yes, query, hypothermic mitomycin. We agree with this. Okay? But this is only when you want to bladder preserve. Primary option would be to bladder non-preserving. Okay? Add-on treatment, now the medical oncologist can wake up. Okay.
So we're having a Niagara trial, sir, in which
This is what it is.
right,
Okay.
so durvalumab is given in the neoadjuvant setting,
Yes.
and this is the first and prospective trial which have shown that.
No, that wasn't the question. So is perioperative, i.e. neoadjuvant and adjuvant becomes the standard? This was perioperative.
This is perioperative.
Yes.
So for adjuvant, we are having 2 trials, already giving checkmate 274 trial and
No.
other trials, which have shown a DFS advantage.
No, sir, not that was. So in that one, they did not give neoadjuvant.
Right.
That's what I'm saying. Perioperative, neoadjuvant plus adjuvant, you say it is superior to either neoadjuvant or adjuvant.
It is
Am I-
superior.
Huh?
It is superior, sir.
Okay. Anand Raja, sir, I'm going to come to you. I know
I am
that's why
not
you were
so
shaking
sure
your
that
head.
the perioperative durvalumab, because we have a lot of data right now. I think this is a good trial, but has added to the sound without making too much sense out of it. You have the checkmate 274 trial, where if you gave neoadjuvant chemotherapy, added cystectomy, and then gave nivolumab, there was an over survival benefit to it. Now you've given perioperative durvalumab, where you've given both before and after. Now we don't know whether the perioperative durvalumab is better than or equivalent to the chemotherapy followed by surgery followed by the nivolumab. That we don't know.
Yeah, that was.
Only thing is,
so,
the checkmate 274 was only for high risk we have
No,
given.
no, it was also for patients who did not go down, for patients who received neoadjuvant chemotherapy, if they were not downstage to T3 or less, all of them, or node, if they did not become node negative, all of them got nivolumab. So in the checkmate 274, there were also patients who received chemotherapy who were not downstage to a sufficient extent possible.
Okay, I'll ask you this question. Is that a fair trial to do? I just felt it was loaded to show that durvalumab works. First
Yeah,
of all, you are
again-
giving in neoadjuvant setting, then you are giving it in adjuvant setting. I would have liked both just in neoadjuvant setting or adjuvant setting for this one as well.
And here also, like yesterday, I'm stuck
No,
like a
that's
tape
the reason I am
recorder.
asking you.
I'm stuck like a tape recorder, and today also I'm stuck like that tape recorder that is there today. Now we know that the Vesper trial, although the 5-year OS of the Vesper trial was not significant, but the DFS curves and even the OS curves have diverged very, very significantly. So if you wanted to say that, the perioperative chemotherapy or the immunotherapy works, so the standard of care arm should have been something that is good. I would have loved this trial
Okay.
if you...
I will ask Amit Kumar.
Yes, sir.
Yeah, okay. So my view on this one is the versus the standard of care is what is our standard of care. So what is wrong in having one of your comparator arm as standard of care?
The standard of care now is for bulk of these patients would have been neoadjuvant chemotherapy with cystectomy with nivolumab would have been the standard of care arm. That should have been compared to the standard of
I'll
care.
ask.
Yeah. So that's one part. The other is we have to see whether neoadjuvant is working good or the adjuvant.
Yeah.
So might be durvalumab one arm only with neoadjuvant and the other arm only adjuvant setting. Could be like that.
Or
in
the
this
other
trial.
one would be just having durvalumab in the adjuvant setting for the
yeah.
gem cisplatin people as well. Yes?
Definitely.
But I felt they were comparing it to the standard of care without maintenance IO. Okay?
But I think this study is long. I think recruitment period is long. So over the period, I think such studies will come. So anyway, NST is the standard of care, and immunotherapy has a role. All this it proves further that immunotherapy is a standard of care. It should be given for curative bladder cancer, muscle.
What if I take out gemcis out of it? If I just give durvalumab before, do the cystectomy and give durvalumab after.
That will be not a standard of care because it is already proven that neoadjuvant has only for platinum ineligible patient. We can think in case basis. Such studies are going on, but for till now standard of care is
Also the phase 2 trial of neoadjuvant pembrolizumab, which is for the bladder, for the cisplatin ineligible.
Fine.
The point here is, what is the concept was, this immunotherapy trials have changed the management of metastatic muscle invasive bladder cancer upside down. We all know that, and next session is on that only. Now they are being tried in the neoadjuvant setting and the perioperative setting to see their benefit, whether they are working or not. The responses are much more durable, they are long lasting, and they persist even when the immunotherapy have stopped after 8 cycles, right? And so this is first step in right direction. There are many more trials which are going to come in next couple of years, which are going to compare one immunotherapy with other immunotherapy.
I'll ask one question. Is perioperative systemic therapy going to become the standard of care? I'm not going to mention the drug. Perioperative systemic care is going to become the standard of care?
At present,
Yes or no?
yes, sir. Yes.
Yes, okay.
So
fine.
definitely.
So T0, when we do a cystectomy, Kashyapi sir, is that a good outcome?
Yes. T0 is a good option.
And do you think somebody having both chemotherapy as well as immunotherapy, which currently are expensive, 34% is acceptable for you?
34%.
T0.
It's a good response. Yes. The issue is going to come. What do we do after if there is a clinical T0?
Okay.
And that is what is going to.
So they were looking at both this one, T0 rate and event-free survival, and these were the events. And they have said that there is a difference between these two. Okay. So just to, I've got, fine. So I'm just going to say, I think this is a practice-changing one if patients can afford. So there are those two parts of the sentence. We agree with that? Yeah? You're sitting beside a radiation oncologist.
Yeah.
She will say that neoadjuvant chemotherapy, radiotherapy followed by adjuvant radiotherapy is better. No. Okay, so this one is an extension of the similar one. People in the know. HER2, what is the overall expression in bladder tumor?
Right, there are multiple studies which are done, and the reference range which they are quoted, it can be from 9% to 81%.
That's
If
what
you
I,
dig
even I
deeper-
read.
Right, if you dig deeper, the micropapillary variant is having a nearly 40% chance. So whenever in the histopathology report you will see the micropapillary variant as a variant histology, check for HER2/neu. They are more likely it is going to work. And now antibody drug conjugate have come because this is a desitamab vedotin, which is a
And for the
smart
for the
chemotherapy.
breast, we use Herceptin.
Right.
Why don't we use here?
Right. So this
Cheaper?
Is right. So Herceptin is an anti-HER2/neu drug, right? There are nearly 8 anti-HER2/neu drugs. It is being used not only in breast cancer, it is in G junction, gastric cancer, colon cancer, and so many other cancers also. Urothelial cancers, now they have shown that this HER2/neu positivity rate is significant, and this, if we combine antibody drug conjugate, which is nothing just a smart chemotherapy, in which anti-HER2/neu agent, which is desitamab, which is RC048.
No, sorry, that wasn't the question. My question was, can I use Herceptin instead of desitamab vedotin? Are they similar?
The difference is, in this anti-HER2/neu is combined with chemotherapy. The chemotherapy partner is MMAE, monomethyl auristatin E. This is the chemotherapy drug.
Yes.
And the desitamab, which is RC048, it's the anti-HER2/neu component, right? So when they are coming together, they are known as antibody drug conjugate, which is something like it's a smart chemotherapy, right? When they are combined with the anti-PD-1 antagonist, that is toripalimab is drug, which have shown that it's a phase 2 trial, no doubt, and have shown that these patients having EFS advantage, pathological CRs are higher, and these patients is proving to be tested in the phase 3 trial also.
I'll again ask my baseline question.
Can-
Because we don't have
Yes.
this now, yes?
Yes.
If I have a micropapillary tomorrow in my clinic and I do HER2 positive, can I use Herceptin there?
Herceptin, there is no trial as such to answer this because it is not.
But
being
this
tried.
is not available to me. And you say that micropapillary expresses in 60 to 70% of the cases.
Then you are having transdermal deruxtecan, which can be used later on down the line, right?
You
Not
only
upfront.
go for expensive medication, isn't it? Medical
Available in
oncology.
the,
It's
it
not-
is available in
Herceptin is
India.
cheap. I'm saying will
Transdermal
Herceptin
deruxtecan is
work?
available in India. No doubt, availability and accessibility is not an issue, and
It's non-affordable even to me.
it's a compassionate access is there. So.
Yes. Okay. So they are Herceptin.
Sir, what happened that all this trial, they begin with, we have to check, but generally they begin with somebody had started with trastuzumab in where they have not shown any benefit. So then it came that can we get better? Then came pertuzumab, then other
No,
drugs.
no. Okay. My again asking you in a different way. Let's say that we do a randomized control trial between Herceptin and this one. You think this one will be better because this is targeted chemotherapy to those cells. Is that what you are saying?
What I'm trying to convey is,
Kumar sir is there to answer.
So
Yes, sir.
this is the fair question what you are asking. So trastuzumab has been tried at multiple places. So trastuzumab as compared to not this drug, because that's not direct comparison, TDX if we take, it's not, it doesn't work as well. If you take, this has been tried in lung cancer, salivary cancer. So if you take TDM1, which is a bit like similar kind of, you load this antibody with chemotherapy. It works better than trastuzumab. So trastuzumab take gastric cancer. It does not work. TDX, it looks like it works. So is this a better drug for targeting HER2? Yes. It gives additional benefit. Trastuzumab, apart from breast cancer, think about, you have a HER2 expression in so many places. Where we have seen it being used? The reason has been alone antibody, it worked in breast cancer, but other places when it has been tried in multiple places. It has not been able to give those kind of results.
Thank you. So probably this is as it was quite well presented by you. So there wasn't anything much to add on to that. Did you understand this HER2 expression IHC 1 plus 2 plus 3 plus?
Right.
One sentence. Tell me what the difference is.
So 1 plus is taken as negative, 3 plus is positive, and 2 plus can be equivocal.
I would
So the
have
results
said-
are amazing when it is 3 plus.
I would say negative as negative rather than
So,
say 1 plus.
it's the
There are
best.
trials in which low HER2/neu also, the transdermal deruxtecan seems
So
to be
anyhow,
working.
HER2 has to be seen expressed, whether it's 1 plus, 2 plus or 3 plus, this drug is going to work. So it's the beauty with trastuzumab deruxtecan or with this
Similar
drug.
to the PDL1. Okay. So the main thing that I wanted to look this, the YPT0 seems to be very high in this, but majority of the time even when the pembrolizumab was used in the phase 2 setting, the T0 rates were the same, 60-70%. But when it came further on, it didn't seem to have the similar efficacy. But this is something which is we have to make a better effort at bladder cancer compared to what we are doing with prostate cancer. So all the numbers are extremely good, which are generally what you expect in a phase 2-1. Unless we come to the phase 3, we won't know whether it does make a difference or not. Okay, so I'm going to say this is a new concept, that's one. Second, it's not available in India, but it gives an indication towards how the future is going to look, in that everybody who has got a bladder cancer is going to survive forever, whether they have radiotherapy or not. Yes, so I've said something that is exciting, but currently we don't have access. It might be another 5 to 6 years we don't have access to it. But it's a new concept that we understood. Now there are 2 radiation oncologists. Kaustav Talapatra? Okay, fine. So it's now your fee. I've got about 8 minutes out of the next 10 minutes. Bladder preserving in high grade. I'm going to ask Anand Raja sir first. Yeah, high grade TA. Actually, it's the TA part is missing. Do you think as a concept this is right? This is high grade. So high grade NMIBC radiotherapy.
No.
Okay, that's single answer. Balchand Kashyap sir, if you were going to use radiotherapy as an outcome, yes, what would be your outcome be? Bladder preservation or patient survival?
Both. Ideally,
Which one as the primary outcome?
it depends. So in an elderly patient, I would prefer a bladder preservation. For a younger patient, it has to be survival also.
For whatever reason, high-grade TA doesn't tend to come in very elderly, isn't it? Majority of the time, once they cross 70, they have muscle invasion. High-grade TAs are generally 60s, early 70s patients. They don't tend to be octogenarians.
See, then again, when you do a high-grade TA, it's like doing a disease for a you are treating a non-invasive disease as of now. It's not become a T1. You're doing it for a pre-invasive cancer.
Yeah.
So the outcome measures for you are going to be slightly different. So when you're doing an invasive surgery for a high-grade TA, your endpoint has to be that this patient, after this treatment, has to survive for as long as he would have otherwise survived without the disease. So it has to be 5-year OS and 10-year OS. The endpoint cannot be...
Yes. So this is the overall survival.
This is not TA only. I think it's TA and T1, right, in this trial?
TA, T1, because the difference, they don't have the cystectomy pathology. Yes? So TA, T1. Is this acceptable? There are 2 radiation oncologists.
This is a starting point.
This is the end point.
This is a starting point as a benchmark, because this was the first trial which reported on the results. Before that, we had no idea whether it would be 50% or 90%.
Okay.
So as a starting point, as a benchmark, this is its utility.
Okay. So the reason why I was coming to this one is, if you saw in the other non-cystectomy options, bladder preservation without radiotherapy as an option, even there the survival was around 70%. So my feeling is, even if you didn't give them radiotherapy, they would be there.
Maybe. We don't know that, but maybe.
Okay, because I want to draw to the so you think this is a start and we'll have more studies in this. Conceptually, does it work for an NMIBC?
See, we didn't know that. That's what I was saying, that we didn't know before this trial. Now we know
in
that
other sites,
it probably does, but we definitely need more data, because...
No, sorry, what I meant was, does it work, radiotherapy work in a non-invasive setting in other sites?
DCIS, breast?
Breast, okay.
That's the biggest example I can think of.
So this subgroup of patients in bladder has been very underutilized with radiotherapy. As PM Vada rightly said, that we never knew what happens to this subgroup. And in bladder, radiation has been reasonably underutilized. So we really don't know. And it's a good starting point to know what's in store in the future.
Because the reason why I'm saying is, in the conclusion, the says at 3 years, 88% of the patients remain free of cystectomy.
Survival would be my
Yes.
more
no, that to
major
add that as a
consideration.
conclusion, and it's the same thing is mentioned to the summary to the general public.
Sir,
Yes.
one
What they spoke about DCIS in breast, context is important. So when you say radiation in breast cancer, in pre-invasive DCIS, radiation follows surgery. There is no definitive radiation there. It's only adjuvant radiation after surgery is being done. So context is important.
And equally, sir, actually CIS is considered radio-resistant.
No, considered.
So
That's
I
the
mean,
reason
just
she
need to
said
say,
it's a starting
I don't
point.
think we can
Considered.
extrapolate
We
from
don't
the
know.
breast.
There is no evidence to say that it doesn't work.
I mean,
That
this
doesn't mean that there is evidence to say that it works. It is conceptually doesn't work. That's the reason I was asking, does it work
So
in
I
other
guess the
sites?
hypothesis that they tested was because it works in a higher stage, why shouldn't it work in a lower stage? And we would not know unless we tried, unless we did a pilot, and that's all.
Okay, so this is recurrence-free survival, and as you can see, it doesn't seem to be, at least in this one, it doesn't. That's the reason in the conclusion they said you will keep your bladder, whether you'll be alive or not, or how symptomatic, that's different, but you'll keep your bladder.
And a significant proportion of patients were T1. So definitely we know from all the other sites that T1 radiation works, like starting from head and neck sites to prostate to various sites. T1 is not adjuvant, it is radical radiotherapy in cervix, in vocal cord, and oropharynx, it works. So we really don't know.
Okay.
I think it's
and
a good study.
this one, I thought it was, that's the reason I asked Anand Raja sir at the beginning. So cancer-specific survival was comparable seen in patients with T1 who undergo cystectomy. That's why I asked you the number before. He said 80 to 85%.
That could have been contributed by a salvage treatment after the radiotherapy, probably. I'm not sure about that.
No, this one was historical comparison for patients who underwent primary
Yes, I know,
cystectomy in T1.
but in this cohort, the overall survival and cancer-specific survival will also depend on what they get after failure of CTI.
Not that many patients underwent cystectomy actually.
Not
Very
cystectomy,
small.
but
Yeah.
if they had a recurrence, they could have undergone TURBT, or they could have, if their disease were more metastatic, they could have got some systemic therapy later without getting cystectomy. So probably that affected survival.
So as of now, do you agree? I'm looking at the radiation oncologist.
Yeah, I agree with this statement.
No, the thumbs down for now.
The cancer-specific survival comparison.
That's such a big one there in the screen.
Well, I would not
You
agree
would not.
because this is the only data that we have. So this is useful on its own to launch better trials in the combining with immunotherapy
No,
and
I
other
do the
options.
other way around. What I don't want them to go home tomorrow and say that for
That
G3.
that
yes.
is true.
So I was mainly going towards take-home messages that I can practice tomorrow. Okay, this one, hypofractionated chemoradiotherapy for bladder. Okay, give me 2 sentences why hypo is better compared to standard. Kausthav sir, why hypo is better? We are going hypo with respect to prostate. We are doing the same with bladder. Why is it better?
Prostate is different from bladder. The alpha by beta, the biology of prostate is different from bladder. Prostate, definitely hypo is better than standard fractionation, moderate hypo. Bladder, we don't as yet know whether hypo is better. We are trying to prove that it's equivocal. We don't know whether it's better or not.
So you're saying non-inferior. Okay.
All the attempts are to prove that it's non-inferior.
Non-inferior both with respect to toxicity and survival.
Efficacy, definitely yes. Toxicity, both will have different profile. The standard fractionation will have more acute toxicity. The hypo may have more late toxicity.
Okay. Late is when? I didn't know when you call late, because they always say acute toxicity and late.
Beyond 3 to 6 months. Mostly 3 months, but some
Okay.
studies use 6 months.
But you don't finish your radiotherapy in that time though.
Radiation is a month and a half.
Month and
Month.
half. Okay. So this one was hypofractionation versus standard fractionation. And I feel for the convenience of the patient, as long as we are meeting both the criteria, i.e. the efficacy is same, and for us, the toxicity is same, if better, inferior, as in the toxicity being inferior with the hypofraction. Do you think hypofractionation will give us better toxicity, Dr. Priyamvada?
We expected that it could lead to some increase, especially when we are combining with pelvic nodal irradiation and combining with concurrent chemotherapy. In our patients, we did not know what would be the data, but our experience has been rather
Fine.
good.
So these 3 things, I just put this one from the slide, because I kept on reading it, I could not understand. WRBT, SARBT, do you think any of them will become standard? Let's say in the next 5 years, we will all be doing DART or SART, or we'll continue with WBRT?
I think we managed to show that we can give more dose safely, but it didn't have any.
No,
it
but
didn't have any effect.
The third arm, even I have a problem with. It's too high a dose, I think, and we really need to prove. The second arm is good, but the third arm is, the DART arm is very high
So
dose.
there is a radiation oncologist practicing in a single center with their own linear accelerator, you would say that just go for the WBRT because you know how to do it.
Yes.
And you need more understanding of anatomy as well as a bit of physiology to do other two.
And the planning also.
Okay.
The other two.
So
but third one is dosimetrically also it is questioned.
So in India, as a wide practice, you think WBRT is going to be the standard for now? Okay. So that's why I said I didn't understand that one. Okay. Oh, this one was there. Okay. I'm just going to look at the inclusion criteria. Nodal yield of less than 10 being an, I didn't shake my head. It's a surgical outcome. So Anand Raja sir, do you think we should be sending them, if you do a cystectomy for a T2?
I think if you have a nodal harvest of less than 10, you should stop doing a cystectomy.
Not that way. I would say that even we have done extended versus limited, there is no difference in survival. So why should I do extended? Or have
you may not do an
more?
extended, but a nodal harvest of less than 10, I don't think is...
I'll stop asking surgical oncologist. I'll ask a uro. Apologies. Kashyapi sir, do you think that's an indication for giving adjuvant treatment?
I don't think so. T3, T4.
No, those are all individual. Yeah. They are not all.
Only for a nodal yield less than 10, I would not consider as of now.
Okay, that's one. And second is, they didn't say what it is downstage to. If your pre-operative clinical staging is pre-chemotherapy, clinical staging is T3, even if it becomes T0, that's an indication for giving adjuvant treatment. What do we think on that? Pankaj?
No, I don't think so. So that should be the only criteria for...
Not only, these were all...
So downstaging should not be a criteria for adjuvant.
What I'm saying is this is pre-operative, pre-chemotherapy treatment, staging, given neoadjuvant chemotherapy, and then they were downstage. They didn't say downstage to T2 or anything. They said this, if this is a clinical staging, they need to go for adjuvant chemo. Okay.
No, sir, I won't.
Fine. So as of now, this is a new concept, as you have mentioned, something that can be considered in high-risk patients. I don't know who those high-risk are. I've asked Vedang as well and say, if a patient didn't receive neoadjuvant chemotherapy, where do I go for adjuvant chemotherapy? Where do I go for adjuvant radiotherapy? Margin positive?
In the trial, if someone didn't have NACT but they were eligible for chemo, they completed adjuvant chemo and then went on to randomize.
Okay. So you would, as of now,
adjuvant chemotherapy would be standard. Yes, okay. Yes, no doubt.
So key messages: BCG is still the king. Perioperative treatment might be the new SOC. Okay, what the drug will be, time will tell. But that's what is going to be the new SOC. Thank you very much. Sorry in case if I haven't included everyone in this.